Okay, good afternoon, everyone. Um, Welcome to our very first webinar, a series of 5 webinars throughout this year until March next year. My name is George Danyika. I'm a
That
heart
doesn't work.
failure.
Okay.
Okay, I think someone was. Should I just mute all for now? Okay. I've muted all for now. If you need to speak, you will be able to just unmute. As I was saying, I'm George Danyika. I'm a program manager at Health Innovation Network, leading on heart failure. It's really good to see the delegate list, which has got so many familiar names from a regional and national perspective. So a lot of people I've worked with on cardiovascular disease over the years. Um, we do have two speakers or three speakers, two sessions. Although it's two sessions, they're really quite packed with some exciting stuff around heart failure. So we will try to keep to time because we will have those speakers speak one after the other. Then we have a dedicated question and answer session straight after that. We also want to make time for a Slido session where we will be able to ask a few exit questions in terms of how the session has gone and any future topics of discussions there. Um, as I'm sharing there, I'm from the Health Innovation Network. The very first slide is just showing that we are a network of networks there. For those who do know, we do have 15 health innovation networks spread along the map, as you can see. But we work with our ICB and our NHS colleagues, NHS England colleagues on the heart failure program. So we are just hosting a series of webinars for um, education and training on behalf of the heart failure group. Next slide, please, Christine. Okay, as you've registered, that's the list of our speakers today. So we're running the session until 2 o'clock. We do appreciate that it is lunchtime, so feel free if you want to be having your break or your dinner during the session. We've got our heart failure chair, Tom Green, Dr. Tom Green, who will give a bit of an intro before our speakers. But this has really come out of our heart failure group when we did an exercise to see what it is that we want to focus on around education and training. So we're really excited to have this audience and these exciting speakers. On the next slide, please. Very quick housekeeping. I have muted everyone, but feel free if you want to ask a question, pop it in the chat. I did say we've got protected time towards the end for question and answer, so we will be able to give you airtime towards the end. Also, if you do not have access to the chat function, please just email Christine at that email address there. We will circulate the slide after this, and we are also recording the session itself. On the next slide, please. So you all do know the agenda as you've signed up. So that is the agenda. We'll try to keep to time as I've mentioned. But at the same time, we really want to get through the agenda before most of you leave and do the feedback session, which we really think will add value to either the learning or what we need to focus on the next sessions. So without further ado, I'll pass on to our chair, Dr. Tom Green, who will give a preamble of why it matters around early diagnosis, then pass on to our speakers. Thank you.
Thanks, Joe. Nice to see everybody, and it's great to see such a healthy turnout of people coming to listen to these wonderful talks today. So thank you all very much. To those who I don't know, I'm Tom Green. I'm a consultant cardiologist with special interest in heart failure at Northumbria Trust. I also chair the North East North Cumbria Heart Failure Group as well. Thank you very much to Joe and the team at Health Innovation, North East North Cumbria, for putting this together. It's wonderful to have a chance to kind of listen to these great presentations and also kind of touch base with colleagues from and across different specialties from different trusts within the region and further afield as well. We are looking at early diagnosis of importance of early diagnosis of heart failure. As we all know, its mortality remains still very high in the first year, especially, and diagnosis is one of the key things throughout primary care, secondary care. And we've got two wonderful presentations today. We have Aisha Marshall and Emma Cowan, who are kindly going to talk to us about heart failure and lower limb edema. So early recognition of what is likely to be heart failure and what isn't, and what we should be doing about those things. And we then have Dr. Yaz Samaraj, who's a consultant and cardiologist, to talk about valvular heart disease in heart failure as well. So two brilliant presentations, and I will let them carry on because you're not here to hear me speak, but to listen to these great talks. Thank you very much.
Thank you, Tom, and thank you everybody for inviting me to this session today. My name's Aisha Marshall. I'm a nurse consultant in tissue viability, and it was quite interesting how I found out about this network and how things were working, and spoke to Joe and said, let's see if we can really focus on skin health and lower limb edema, just to see if we can network and bring things together better so that the patient receives the best management, really. So my focus is really on compression and heart failure. Next slide, please. And next slide, thank you. So really looking at heart failure, one of the consequences is lower limb edema or swelling. It's very, very common. However, if not treated, can cause to leaking legs and further problems for that patient. And from a tissue viability perspective, faced with leaking legs is a big problem because it can take lots of management and lots of intense care for that particular person as well. Those key symptoms often tend to be swelling in the feet, in the ankles and in the legs, but may also present with shortness of breath, rapid weight gain and fluids building up because the heart can't pump effectively. So one of the keys is really identifying the cause of the problems. Why is that swelling there? Next slide, please. So the assessment is key, really, and always consider cardiac as a cause before starting any compression. There has been a little bit of a myth or Chinese whispers, we may say, that if a person has lower limb edema and cardiac problems, we should not compress. That's changed with national guidance, but the key is assessment. We do know that swelling may have multiple causes. It could be down to venous insufficiency, lymphedema, or even arterial problems. But if that swelling does not improve with cardiac treatment, it could also be down to lymphatic failure or lymphedema. So early assessment prevents complications and inappropriate treatment. That assessment is key. Let's get that underlying cause diagnosed and then we can treat correctly. Next slide, please. So part of our clinical assessment will be looking for the symptoms within the skin, within the swelling. Is there heat and pain? Swollen legs don't always mean edema. It could be underlying cellulitis, for example. So that might present as redness with heat and pain. And therefore we need to signpost for antibiotics or look for the underlying cause of that cellulitis. We're also looking for different risk factors. And is there any indicators of venous disease, arterial disease, lymphedema, and to exclude lipedema as well. But always focusing on what is the circulation like and can we identify the cause. So that clinical assessment may well include the ABPI or the ankle brachial pressure index, but that reading may also be unreliable if there is swelling in the lower limb as well. So it may give a false high reading. So really the key is around that assessment, but also consider further tests, which may be a vascular assessment or even blood tests for diabetes or anemia. So therefore the referral process may include referral to GP or vascular services, or even lymphedema clinics as needed. And next slide, please. Thank you. So safety first. Really think about that safety, because we don't want to apply compression if decompensated heart failure is present. So that's with the following symptoms as indicated. But if stable with compensated heart failure, we may consider reduced compression, but start cautiously, start slowly. But that must also be agreed with the heart failure or the medical team as well. Next slide, please. So really thinking about the management depends on the cause of the lower limb edema. So it may be compression therapy if safe, and that is to reduce the swelling and the edema. It helps improve some of that circulation by shifting that fluid, and also prevents long-term leg ulcers and also cellulitis as well. The forms of compression may actually include compression stockings or garments. It may be bandaging or wrap systems that the patient might be able to apply themselves. It could be referral, as mentioned, to the lymphedema service. Thinking about that skin care, because swollen skin is stretched and it can become itchy as well. So again, thinking about moisturising, trying to encourage movement and exercise, limb elevation if appropriate, and also lymphatic drainage. But the key advice really is about reporting any increased pain or swelling with that edema and seeking urgent help if there's any spreading signs of infection. Next slide, please. This is a flow chart, which again, we can pop in chat. It may be that you can't see it clearly, but it really talks you through the pathway for lower limb compression therapy for patients with heart failure. And this is lifted from national guidance as well. So this flow chart just talks through the red flags and thinking about the symptoms, whether to apply compression or not. Next slide, please. Patient information can also be downloaded from this website, and the link is attached. So really patient information around edema and lymphedema, which talks about the symptoms, the causes, diagnosis, treatment, prevention, and just managing skin themselves as well. And next slide, please. So again, Joe just wanted me to mention around what's actually happening in the North Cumbria area. So it's just raising awareness about different work pathways that are going ahead. So there is a group called the Northern Tissue Viability Professional Forum, which is a group that I chair. And that comprises of tissue viability nurses and also podiatry. We meet face-to-face quarterly. And it's very much about networking and standardising practice that's already published from the National Wound Care Strategy Programme. We look at variance in practice also, because what we've noticed is that we are, as organisations, working in silos. So we've started developing collaboratively different pathways, for example, overgranulation, pyelonephritis or sinus management and chronic wounds, lower limb management, surgical wounds, pressure ulcers and skin tears. There's other pathways that are added to that list as well. So it's a very functional group that's developing lots of resources that will be hopefully adapted for acute, community and also primary care and all areas that were wanting it. Also, just awaiting approval, which is very imminent, is a wound formulary. And that will be hosted on the ICB website once it's finalised, but that's imminent as well. So that will provide information about formularies and dressing products that are available and bandages as well. So that was a very quick whistle-stop tour, really, of sort of tissue viability, how we can work with you and as part of the heart failure collaboration. And I'll stay around for any questions later on. Thank you.
Excellent. Thank you very much for that. It's much appreciated and very informative. Should we just press straight on then? And Yaz, if you wouldn't mind. Thank you.
Yep. Can you hear me all right?
Yep.
Perfect. Just to let you know, I've got a trainee with me. Just in case you see someone popping in and out of the picture. Thanks for inviting me to speak. I'm Yaz Samraj. I'm a consultant cardiologist at Durham and Darlington. My special interests are heart failure, echo, and cardiac CT. Next slide, please. So just to carry on the focus with early diagnosis, and I think that's, as Thomas said, really, really important, particularly with heart failure. And it's not just early diagnosis, it's getting the correct diagnosis as well. So I'll talk you through some challenges that we face in cardiology in getting that diagnosis right. And don't forget, heart failure isn't a diagnosis. Heart failure is a syndrome that's caused by something. And the question is, what is that something? And getting that something right is important to institute the correct management. Next slide, please. So what I'll do is cover some common challenges that we face, particularly when we've got coexisting valvular heart disease and heart failure, and how we go about tackling them. It's case-based, so there's 3 cases. If we have time, we'll go through all 3. If not, we'll maybe limit it to 2. I'm not going to get too nitty-gritty, but we'll talk about some general principles, and I'll try and drop a few pearls of wisdom in assessing these cases. It's by no means exhaustive. There are a few echo pictures, but I'm conscious this isn't really an echo meeting, so I'll try not to delve too much that way. Next slide, please. I hope this is a little funny video that I found on TikTok. So hopefully it'll play. Just an illustration that I appreciate this is sometimes what life is like. So do you want to try and play that video? I hope the sound goes through. The sound isn't playing. I don't know if you need to click on that speaker at the side. Okay, I'm not hearing any sound. I don't know if you guys are. I'll summarize the video. Basically, it's a doctor who's trying to hear who thinks he's heard a murmur, and initially, when it says intention, he provides a very concise description. He says, I think it's a pansystolic murmur. I can feel an apical thrill. This is definitely mitral regurgitation, secondary to mitral valve prolapse. And then when it says reality, he examines the same patient again and says, that sounds weird. Can we get an echo and consult cardiology, please? And that sometimes is what life is like, which I appreciate. Next slide, please. So, however, recognizing not normal is a valuable first step. So the heart sounds are normal, the heart sounds are abnormal. That's okay. That's a great start. Auscultate with intent and focus. What I mean by that is it's very easy when you're seeing patients, particularly when you're thinking about things, you're going through the history in your head, trying to work out a differential diagnosis, and you're not actually looking for a murmur or an abnormal heart sound. You may just miss something. So always when you put the stethoscope on the chest, actually listen with focus and intent and try and hear something that's actually there. Sometimes maneuvers can bring murmurs out. So if you sit the patient forward, get them to hold their breath in expiration, that can bring out left-sided murmurs. If you're trying to hear a mitral murmur, you can roll the patient onto their left-hand side. Again, hold their breath in expiration. If you hold the breath in inspiration, that will bring out right-sided murmurs more. So these can be helpful. It's not just about heart sounds and murmurs. You can get other signs that are telltale markers of valvular heart disease. So particularly with blood pressure and pulse. So with aortic regurgitation, you might get a wide pulse pressure, high systolic, low diastolic, and a collapsing pulse. With aortic stenosis, you would expect a narrow pulse pressure with a slow rising pulse. I once learned this from a mentor on an elective. A thrill is a thrilling sign. Why he said that was because murmurs can be heard anywhere and don't necessarily localize the pathology. But if you feel a thrill, what a thrill is it's a palpable murmur. So when you put your hand on the chest, you feel a little sort of vibration, and that tells you that pathology is likely to be directly underneath your hand. But it's often not there. And actually, the video that I put on the previous slide, the chap said, I can feel an apical thrill, and that led him to diagnose a mitral pathology. Next slide, please. So if you take nothing else away from this talk, this is mainly for my colleagues who work in acute care. If you find a murmur and you see an x-ray that looks like this, i.e. pulmonary edema, recognize that's a very bad sign. So patients who come with decompensated heart failure and valvular heart disease, particularly left-sided valvular heart disease, they have a bad prognosis without intervention. So that needs to be an alarming sign, and that should prompt, at the very least, an inpatient echocardiogram and a cardiology consultation. Next slide, please. So I'm going to go through a few cases now. So these are all cases that we've seen in Darlington. So GL was a 91-year-old male who got admitted with us in February 2025. He had a past medical history of type 2 diabetes, osteoarthritis with previous hip replacement, and a previous lac in a stroke, which left him with no significant residual disability. He was living alone independently and was getting out to the supermarket walking with a stick. He was breathless over a few weeks with no chest pain. His observation showed a slight tachycardia, ECG showed a narrow QRS, and he was slightly hypoxic on room air. On examination, he had bilateral chest crackles, mild pedal edema, and normal heart sounds when examined in the A&E and the acute medical unit and by the consultant physician post-state ward round. His bloods were relatively unremarkable other than an elevated NT-proBNP of above 2,000. His troponin was mildly elevated but static. Next slide, please. This is an admission chest X-ray, which shows pulmonary edema, fluid in the fissure, alveolar edema, upper lobe diversion. Thanks. So the plan instituted by the acute medical unit was intravenous diuretics, planned for daily fasting weights, urine electrolytes, all things that we usually do in decompensated heart failure on inpatient care. He was referred to cardiology and an inpatient echocardiogram was requested. I was asked to see him as the duty cardiologist on that day. I essentially agreed with the assessment. I also didn't hear a murmur, and he was feeling a bit better after IV furosemide, but was still quite dyspneic. So I basically followed the same plan. Next slide, please. So he then had an echocardiogram. I hope this will play. There's no sound here, so hopefully it'll play okay. If you just click on the, hover over the slide and play it. So I appreciate not all of you will have experience with echoes, but the headline point here is that the heart is not pumping very well, which is I kind of expected. But what surprised me a little bit was that his aortic valve, which is that thing sort of moving on the right-hand side, or rather not moving very much, is very calcified, not moving very much. So I was a bit surprised to see this is not a normal aortic valve, and this echocardiographically looks like aortic stenosis, which surprised me because no one heard a murmur, either the doctor in A&E, the doctor on AMU, or myself. And this is not that uncommon. And this is partly why it's important when patients come in decompensated with heart failure to get the echocardiogram, because you may not pick up a murmur clinically. And we'll talk about some of the reasons for that later on. Next slide, please. So you may have heard of this phenomenon called low flow, low gradient severe aortic stenosis. It's a bit complicated, but I'll try and simplify it. So aortic stenosis is graded by echo with a few parameters, primarily the peak and mean gradient through the valve and a calculated valve area. That valve area that you see on an echo report is not an actually measured area. It's calculated by various valve parameters. And that calculation can be influenced by other extravalvular factors, including the LV function, and is quite subject to error. So you're essentially plugging numbers into a calculator. And if you get some of it wrong, that error can be magnified. So it's really subject to error. The typical finding you get in this case of low flow, low gradient severe aortic stenosis is you get gradients that are lower than what you expect to be a severely stenotic valve, but you get an aortic valve area that is low enough to be in the severe range. So it's discordant parameters basically. But you can also get those findings when the valve's actually not narrowed and the ventricles are not pumping very well, and we refer to this as pseudo-severe aortic stenosis. So you've got a bit of a dilemma here when you get those parameters, and you need to do a bit more work to work out what the problem is, and therefore what the diagnosis is, and therefore where you should target your treatment. And sometimes I explain this to patients: is your valve not opening because it's calcified, restricted, and narrowed, or it's not being pushed hard enough? So I describe the anagram of a door. Is the door not opening because you're not pushing it up, because someone's not pushing it hard enough, or because the hinges are a bit worn and torn and need a bit of WD-40, that sort of thing? And the other question to ask is the ventricle failing because the valve is diseased in the first place, or is there another reason? For example, coronary artery disease, which is very common in this particular age group. This chap is a 91-year-old male. Next slide, please. So the report of this echo showed severely impaired left ventricular systolic function with an ejection fraction of less than 30%, and low flow aortic stenosis with these valve parameters with a gradient that's really not very high, but a valve area that's in the severe range. And we use this thing called stroke volume index, which basically is kind of like a surrogate of LV function, how much your heart's actually pumping. And that is how we determine a low flow state. So 22 milliliters per meter squared would qualify for a low flow state. So what I did next, I went to see him again, re-examined him, and this time when he was feeling a bit better, I did actually hear a soft ejection systolic murmur. I could hear his second heart sound, but it was quite soft, but it was certainly audible. If it was inaudible, that would point towards possible severe aortic stenosis. He was feeling better, he was less overloaded. So what I did at this point was I put him on a small dose of bisoprolol because he was euvolemic, and I was aiming to put him on the other 3 pillars of heart failure therapy later in the week. We did a TAVI planning CT scan, and I suggested cautiously titrating his bisoprolol if tolerated to ensure we get good CT images, because we like a nice slow heart rate to get optimal CT images. Next slide, please. So this is what his TAVI CT report came back at. So the TAVI CT looks at 2 things. One, it looks at the heart arteries and the aortic valve anatomy at the top end, but it also looks at the leg arteries to see, is it possible to get a percutaneous valve through the legs, through the aorta, up to the heart practically. And what we get is this thing called an aortic valve calcium score. So that produces a number called Agaston units. Basically, it tells you how much calcium is on the valve. It doesn't tell you about the valve motion, but it gives you a bit of an indicator of whether a valve might be severely stenosed or not. And this is some data from a paper that is used in most trusts, certainly locally. And you get this indicator of whether severe aortic stenosis is likely, very likely, or unlikely. And the astute amongst you will have spotted that this gentleman's number, 1624, falls in a very annoying range where it's neither in the definitely in the unlikely column or in the likely. So we're still in the dark here about whether his valve is severely stenosed or not. Next slide, please. So what I decided to do next was something called a low-dose dobutamine stress echo. And I won't go into the details of this, but the principle is basically you do the echo and you give a drug called dobutamine, which makes the heart pump harder and faster. And you remeasure the parameters and see if you can be any further forward in terms of the valve gradient or the LV function and the valve area. And you basically remeasure things under conditions of stress. So that was my plan, but we ran into a bit of trouble here in that he became acutely septic, suspected chest source, and he dropped his blood pressure, was febrile, and I had to stop all his heart failure treatment because he was very unwell. He also had the extra cardiac findings radiology report on his CT scan, which identified some other problems. They thought he had pulmonary fibrosis, and they also found a left renal mass, which was suspicious for a renal cell carcinoma. So next slide, please. I had to basically put everything on hold. So we had to put him on intravenous antibiotics, and his sepsis improved, but it left him really quite weak. We spoke to urology about his renal mass, and they said they'd see him as an urgent outpatient to have a look at him and decide what needs doing about this renal mass. Respiratory team saw him about his lung fibrosis, and they thought he didn't really have much in the way of respiratory symptoms, and they were also happy to see him as an outpatient with some lung function when his infection was better. So it was a bit of a dilemma here. So I spoke to him and his daughter, and we decided to pause the workup on his aortic valve, and I actually elected to discharge him with early outpatient follow-up with careful safety netting. So I broke kind of 2 of my golden rules here, in that one, I missed the murmur, and 2, I discharged somebody with decompensated heart failure and valve lesion without fixing the valve. But I explained the risks involved, and I carefully safety netted the patient, and we had an early outpatient follow-up plan. They decided to move him to assisted living because he was living independently before, but they felt he probably wouldn't manage. I discharged him on 4 pillars, arguably very modest doses, but I was quite happy I managed to get him on at least a small dose of everything. Next slide, please. So I saw him 6 weeks later. I don't usually have outpatient slots 6 weeks after discharge, but I squeezed him in as an extra because I was a bit worried about him. So he was doing well. He was using a mobility scooter for long distance, but was managing stairs and getting around his garden fine. He didn't have any limiting cardiac symptoms, but wasn't really pushing himself too hard, and he felt he was getting slowly stronger. By this point, he had a kidney CT and seen a urologist, and they thought he had a small, slow-growing renal cell carcinoma, and they thought this wasn't particularly prognostic, and they basically elected to discharge him, and they said he can represent if he has symptoms of hematuria, but they weren't particularly worried it carried a particularly nasty prognosis. I thought there was still some scope to up-titrate his spironolactone, and I asked the heart failure nurse to do that in the community, and I asked for a repeat urgent transthoracic echo. Next slide, please. So his Repeat echo showed some improvement in his LV function. Ejection fraction still not normal, but improved to 40% from 30%. It identified a regional wall motion abnormality in the LAD territory, suggesting some underlying coronary artery disease. The valve parameters have gone up a bit in terms of the gradient, with still a low valve area, but we're still in that range where we can't be sure if it's severe aortic stenosis or not, because the valve gradients don't quite get there. The stroke volume index is still low, so we're still not sure. I was a bit astonished that his lung function tests were really good for a 91-year-old with pulmonary fibrosis, so that affirmed in my head that his symptoms were not due to his lungs. So I went back to plan A and I decided to do the low-dose DSE again as an outpatient. Next slide, please. So if you just play that for me. So this is the resting image before we've even given any dobutamine, and it's a bit jerky, but the ventricle is performing a little bit better than previously, and the valve is still very calcified and narrowed. Next slide, please. So don't agonize too much about this. This is just what we call how we measure the valve gradient. This is the Doppler signal, and it doesn't quite meet the threshold for being severe. The conventional set threshold is 4 meters per second, and it doesn't quite get there. It's kind of just over about 3.5. Next slide, please. So we give some dobutamine next, and as you can see, the heart's now pumping faster and also pumping harder. I appreciate it's a bit jerky. It might not transmit that well over Teams, but I hope you can appreciate it's doing a bit more pumping. Next slide, please. So we measure the gradients again, and they cross the 4 meters per second mark, and we did some detailed measurement and analysis on it. But basically, we thought it was severe aortic stenosis. Next slide, please. So the conclusion was classical low flow, low gradient, severe aortic stenosis with contractile reserve. So on that basis, I referred him to have a TAVI, a keyhole aortic valve replacement. He had this done in October. This is about 6 months, maybe 8 months after his initial presentation. He had no early complications and was discharged, I think, after about a day in hospital. His post-procedure echo after the TAVI actually showed his ejection fraction had pretty much almost normalized, and he had a well-seated TAVI with no paravalvular leak and acceptable gradient. So he's had an excellent result from the TAVI treatment. Next slide. So that's that case. I'm sure we can have questions at the end. We'll probably just get through the cases. I've got an eye on time. So this is a different case. This is a 76-year-old male who came to us in January 2024. He had a label of a previous myocardial infarction in 2008. We didn't really have much details. It was a bit of a long time ago. He had depression, a hiatus hernia, paroxysmal atrial flutter. We noted he'd been admitted a few months earlier under the elderly care team with confusion and pneumonia, and some concerns regarding chronic cognitive impairment were raised. He was discharged to temporary placement, and the GP was asked to chase a memory clinic appointment for assessment of cognitive function. He was admitted on apixaban, bisoprolol, atorvastatin, and lansoprazole. He was coming with breathlessness and chest pain and was very hypoxic, more so than the last chap, 15 litres of oxygen. His ECG showed inferior Q waves, but no ST or T wave changes, and some ventricular ectopics. On this occasion, the cardiologist, who wasn't me, appreciated a possible pansystolic murmur. His troponin wasn't elevated, but his NT-proBNP was. Next slide, please. So, as predicted, given the oxygen requirement, his X-ray looks a lot worse than the last chap, florid pulmonary edema. Next slide, please. So this is his echo. Again, we'll let that play. So what you can see here is, again, the resolution may not project very well over Teams, but he's got a regional wall motion abnormality, and what you're seeing here is the anteroseptal wall and the posterior wall of the left ventricle, and the posterior wall isn't moving as well. And that fits with the Q waves noted on his ECG and the previous label of a heart attack. So I surmise that he's probably had an inferior STEMI in the distant past, and that's what we're seeing on this regional wall motion abnormality here. In addition, the posterior leaflet of the mitral valve, just where the mouse is kind of hovering, maybe slightly to the left, and the posterior leaflet is being tethered. So unsurprisingly, next slide, please. When you put some color flow on the mitral valve, just play that image for me. There's a lot of blood going the wrong way. So all that kind of turbulent stuff you can see going towards the screen there is a lot of mitral regurgitation. Next slide, please. So what we're dealing with here is what we call functional or secondary mitral regurgitation, and that is one of many types of mitral regurgitation you can get. So it's classified in different ways. So you can classify it according to how the leaflet moves, and you can also classify it from primary and secondary. So by primary, or referred to as degenerative mitral regurgitation, that implies that there's an innate problem with the mitral valve, leaflets, or apparatus itself. What we're dealing with here is secondary mitral regurgitation, where the ventricle is abnormal, the ventricle is affected by impairment and previous heart attack. It's not moving properly, and the mitral valve subvalvular apparatus, the cord air being tethered and pulling on the valve, so that's preventing it closing properly. So that's type 3B on the left with LV dilatation, and those little strings you can see are being pulled down and preventing the leaflets closing properly. So the leaflets are actually normal here, but they're being affected by the performance of the ventricle. And this is a theme in valvular heart disease and heart failure. The valve can affect the ventricle, the ventricle can affect the valve. Next slide, please. So I'm going to discuss a concept here about how you interpret LV function in severe MR. I think it's meant to say that the recording thing is hovering over, but I think it says interpreting LVSF in severe MR. So this is why sometimes, and I struggle to explain this to colleagues and particularly physicians and GPs sometimes, it's not all about ejection fraction. Ejection fraction and LV function need to be interpreted in context. If you have a severely leaky mitral valve, a normal ventricle should respond by becoming more dynamic and vigorous. So it should be hyperdynamic. If you see a ventricle that performs allegedly normally when you've got severe mitral regurgitation, it's actually likely impaired. And sometimes you see this when you send people to have their mitral regurgitation corrected, you see the ventricle is actually impaired afterwards, and people think, oh, the operation's gone wrong, something happened to the ventricle. No, what's happened is the ventricle was actually impaired all along, but it was actually being flattered by the MR. So what this chap's echo is reported as a severe ventricular functional mitral regurgitation, impaired LV function with an infraposterior regional wall motion abnormality, and the ejection fraction was quoted as 45%. So under normal terms, you'd refer to that as mildly reduced in the sort of HEF-MREF range, but actually it's probably more impaired than that. So the overall impression here was severe ventricular FMR, secondary to LV impairment from a distant MI, and based on his ECG appearance, I thought this was a historical inferior STEMI. Next slide, please. So this is important because this is the ESC guidelines about how to manage symptomatic secondary or FMR. FMR, this is without concomitant coronary artery disease, but the themes are quite kind of similar. So with ventricular SMR, as opposed to atrial SMR, the initial treatment, if you just click next, I think it'll bring a little circle up. The initial treatment is optimizing guideline-directed medical therapy, including CRT if indicated. So the first thing is tablets. So I initially gave this talk to my heart failure nurses, and I said, this is where you guys come in. Optimize the medication first. And if that fails and the patient's still symptomatic, you can think about other things, CRT, and you can sometimes do in the bottom corner there, TEER, which means transcatheter edge-to-edge repair. That's a clip procedure that's done keyhole. So those things come later, but the first thing here is not an operation. It's optimize the tablets first. Next slide, please. So that's what we did. So I basically treated him as a HEF-REF, as a severe LV impairment HEF-REF. With medical therapy, 4-pillar medical therapy, or at least that was the aim. We got some further input from our frailty and elderly care colleagues regarding his cognitive impairment, and it was felt that he's not severely frail. We noticed his Montreal cognitive assessment score was a bit lower, 22. So we optimized the medical therapy, and we plan to repeat his echo after doing that and review an outpatients thereafter. And I left the option open for consideration of other therapies if he was still symptomatic and his cognition and frailty wasn't particularly prohibitive. So I hadn't ruled out a mitral keyhole clip procedure. So we got his repeat echo done. On this occasion, it showed severe LV impairment with moderate to severe FMR. So sometimes you do these and the ventricle is severe and the valve lesion looks moderate. Sometimes you do it and the ventricle looks moderate and the valve lesion looks severe. But that's what we got on the repeat echo. I saw him back in clinic a month later, and his symptoms were stable, but his cognition was definitely getting worse. At this point, we optimized the therapy a bit further, so he's now on an ACE inhibitor. He's on dapagliflozin. He didn't tolerate an MRA. So we've managed to optimize his heart failure therapy a little bit. And I decided that that's where we're going to draw the line. We'll manage him with medical therapy only, and I discharged him. Next slide, please. Are we okay for time? 22.
Yeah,
Dr.
we should be.
Okay, I'll whiz through this last case. So for primary care colleagues, this patient actually came through me through primary care. This wasn't an admitted patient. So 71-year-old lady, previously treated by a colleague of mine for idiopathic dilated cardiomyopathy. With medical therapy, she normalized her left ventricular function from being severely impaired. I think she had a broad QRS complex, which she narrowed out with medical therapy as well. Her MRI scan in 2016 showed mid-wall late gadolinium enhancement, which is consistent with dilated cardiomyopathy. She had no valve disease at that point and was discharged after making good improvement in 2019. She had concurrent COPD, recurrent UTIs, and hypertension. She was re-referred back to the service in 2024 with increasing breathlessness, no angina, narrow QRS complex, but an elevated NT-proBNP. Her heart failure therapy was fairly modest, actually. She'd not tolerated an ACE inhibitor or an ARB. She was on Spiro and nebivolol. This, as you'll note from the dates, this is before the Entresto or borderline for the Entresto, and certainly before the SGLT2 era in heart failure. Next slide, please. So this is her echo. Just play that for me. Thank you. So her ventricular function actually looks okay. Next slide, please. I should mention the GP actually didn't mention on the referral if there was a murmur or not. So this is a bit difficult to appreciate, but there is some mitral regurgitation there. But it's quite difficult to see. Next slide, please. So after taking some more pictures, the physiologist reported severe mitral regurgitation secondary to P2 prolapse. The left ventricular function was hyperdynamic. There was only mild AR and trace tricuspid regurgitation, and the RV function was normal. So in order to see things more clearly, next slide, please. I did a transesophageal echocardiogram. So with transesophageal echo, you can see valve disease a lot more clearly, particularly primary valve lesions like mitral valve prolapse. Don't worry if this doesn't project very well, but I hope I can convince you that the leaflet on the right of the screen is going beyond the annular plane and kind of prolapsing back into the left atrium. So the bottom of the screen is the left ventricle, the top is the left atrium, and the valve leaflet on the right is prolapsing back into the left atrium. And on the image on the right, you can see there's a lot of mitral regurgitation going sort of eccentrically from the right to the screen towards the left of the screen, which is a very typical appearance of mitral valve prolapse. So this is a primary valve pathology. This is not a primary left ventricle problem. Next slide, please. So the treatment here is valve intervention, not heart failure therapy. Not the answer here is not modernize the heart failure therapy with Entresto and dapagliflozin. This is she needs an operation or at least a keyhole operation. So I did an angiogram to look at her coronary. She actually had some coronary disease in the LAD and RCA. Her lung function, no remember she has COPD and ABGs weren't prohibitive to surgery. If she didn't have coronary disease, we might have sent her for a clip procedure, but given the coronary disease, we sent her for a surgical mitral valve repair and concurrent bypass grafting. Next slide, please. So she did okay. She had a bit of a long recovery from surgery, but overall she did all right. So I think we're doing okay for time. So key messages: remember to auscultate with intent. Otherwise, you might miss soft murmurs. Sometimes you do miss them because the patient's in pulmonary edema, chest noisy, low flow state. They're not always there. So it's really important to get the echo when people come in with decompensated heart failure. Not least because it carries a very poor prognosis without intervention. It's really important to identify the primary pathology to target therapy. Remember, heart failure is not a diagnosis, it's a syndrome. Ventricle can affect valve, valve can affect ventricle, and it can be tricky to tease out what's actually going on. And finally, be wary of implementing plans based on outdated diagnostics. So with that last case, it would have been relatively easy to say, oh, she's on 2-pillar rather than 4-pillar heart failure therapy. Let's just tinker with the tablets and see how she goes. No, you need a repeat echo because the echo's out of date. Next slide, please. References, yeah, I think that's it. Thanks very much.
Brilliant. Thank you very much for that. That was fantastic. We are exactly running to time, so that's brilliant. Can I open things up then to the floor to see if there's any questions?
Tom, I can see there was 2 questions in the chat, and Alice has put a hand up actually. So go ahead, Alice, because one of the questions was from you.
Yeah, thank you very much. I did pop it in the chat as well, but it was just when you were talking, I mean, it kind of fitted all the patients, but particularly that first patient. The 4 pillars in our kind of elderly comorbid patients, do you kind of have any advice about starting those medications? Should we push for them to be on all of them and then take them off if they don't tolerate them? And also bisoprolol versus nebivolol in North of Tyne, it's non-formulary, but I think it's in the guidance to use in patients over the age of 70. So.
Thanks. Sorry, where are you working?
I work in North Tyneside.
Okay.
As a GP.
And your GP. Hi, nice to meet you. So yes, I would try and get 4 pillars if they tolerate it. There's some guidance about or order of drugs. There's a relatively recent paper by John McMurray and various other people who do lots of guidelines for EAC about orders. But essentially, if you can, the guidance from Strong HF trial is that a little bit of everything is better than a big dose of one and not the other. But sometimes it's just a case of tinkering. Nebivolol. So as you say, I tend to not tinker with drugs if patients are getting on with them okay and they have class effect if they're licensed with a condition. So when I start new drugs, I tend to go for the stuff in the formulary and that's well licensed. But if patients are already on certain drugs and they're doing well and they've got good indication and good class effect, I tend not to sort of move them over for the sake of moving over. Does that answer your question?
That's really helpful. Thank you very much.
Yeah, I absolutely. I'd just say again from a kind of a north of Tyne thing, we tend to predominantly use bisoprolol. If patients are struggling with that, then we might try carvedilol or nebivolol if necessary. But as a general rule, we tend to put everyone on bisoprolol as a first line. Thank you. Is there any other questions?
There was one, Tom, which is probably your best to answer from Catherine. I think it was more nice guidance related, asking around Northumbria. Say, would there be any providing any more guidance since the new nice guidance have been released?
A good question. Not at the moment. Partly because we're waiting to hear what the European Society of Cardiology come up with, and they're going to release their guidance predominantly later this year, we think. We have our own, within Northumbria, we have our own pathway for patients with a reduced ejection fraction, which we follow, which is slightly out with the NICE guidance, but is really what the vast majority of cardiology teams do nationally. There's been a bit of a change for the preserved ejection fraction, which is more managed in collaboration with primary care as well as secondary care, including the use of SGLT2 inhibitors and also MRAs as well. We actually feel that NICE have probably jumped the gun a little bit with the MRAs in HFpEF. Very happy. Any particular questions about individual patients, we're very happy to have it through on the advice and guidance in the meantime. But otherwise, we are going to wait until the European Society guidance comes out to kind of have a look and review things in a bit more detail.
And maybe, Tom, just to add from a heart failure group, we've been working with Sunderland GP Alliance and the CSI team around pathway mapping, and they've done a desktop exercise. So we're in the middle of looking through the information they've provided. I think about there's 8 submissions, or they reviewed 8 kind of pathways in the region, which are similar and dissimilar in other sections of the pathway itself. So hopefully, teasing that apart, we'll be able to give a flavor of what areas are doing or what are the range of pathways that are being followed. So if that's helpful, we will be doing that exercise in some of the sub-working groups and hopefully shade back to clinicians, both primary and secondary care.
Great, that's brilliant. Thank you, Joe. Any other questions, queries?
Now, there's no questions in the chat as well.
Oh, there we go. Something's just sprung up, I think.
Mm-hmm. Okay.
I see that. Hang on. Who was that? So I've just seen a hand appear somewhere.
Okay. I think Catherine is asking for, can you share the pathway you use for primary care? So that offline we might be, if you drop your email, Catherine, I'm more than happy to follow that up, and if I get that, we can share that with you.
There's a hand up there. Asadullah. Apologies if I mispronounced that.
That's okay. Hi, these questions might be quite basic, but I'm a newly qualified GP, so just looking for some advice. Obviously, heart failure is a syndrome, but I've had reports where echoes have come back, systolic functions reduced, but they don't have any symptoms, and sometimes the BNP is normal. Would you still put them on the 4 pillars in that case, or is it just sort of, in that context? And secondly, in terms of reversible causes like, MI or valve disease, once that's been treated and fixed, do we still, and the repeat echo has been normal, do we still count that as heart failure, or do we just not put them on the 4 pillars because the reversible cause has been fixed, if that makes sense?
Yeah, thank you. So with the reversible causes, I think it depends a little bit on the circumstance. So if they've had an acute MI, for example, then it's not uncommon that their LV function would be impaired, and then that might actually, with the kind of basic therapies and revascularization, it might normalize itself. So we tend to just repeat the echo after kind of 6 weeks to 3 months, and then see what it's looking like then. And if it has got better, then we just leave them on their current therapy, and we wouldn't label them necessarily as heart failure if they were asymptomatic. But if it remained impaired, then we would treat them. With valvular disease, it depends a little bit, and as Yaz's talk kind of suggested, it depends on the lesion, and therefore whether it's likely to be the primary cause or not. If you've got an asymptomatic person, but they do have impaired left ventricular function, I would tend to advocate treating them, because we've probably caught them at an early stage of it, and the likelihood is they would develop symptoms. So we try and treat them to reduce their kind of morbidity and mortality going forward, albeit they're often outside of the clinical trials because they are asymptomatic. I think Yaz has got his hand up as well. Very useful.
Yeah, thanks.
As well.
Are you a GP? Sorry, I missed.
Yeah, newly qualified.
Yeah, this is going to be a bit of a problem. I think we've discussed this in one of our networks meetings because of the QOF stuff that's going to come through. That's going to affect you guys about coding. And I think it hits the nail on the head about the problems you have in the sort of case that Tom described. Somebody who has an MI, has LV impairment after their MI, remodels with the conventional revascularization ACE beta blocker therapy, which is evidence based. And how do you code these people? Because you're going to be forced to either label them as heart failure with reduced ejection fraction or not. And the context is really important, because actually those patients have no evidence base whatsoever for the SGLT2s and the Entrestos and the MRIs, etc. So it's tricky, and I think if I'm honest, I'm not convinced that whole QOF stuff has been well thought out. So it's going to be a challenge, but context is really important, and I'd largely agree with the principles Tom has outlined.
Yeah, that's exactly the context. I'm heart failure QOF managing in my practice, and this problem with coding, whether the BNP is normal, they're asymptomatic, the echo comes back, do you code them as reduced ejection fraction? Do you put them on the 4? So this scenario comes up multiple times, and I'm trying to basically get help with it.
Yeah, it's really tricky, and the problem is we're in secondary care, we're not so au fait with the kind of coding as well, so we have the benefit of being a bit more flexible in terms of how we label things, which is not always very helpful from a primary care perspective. I think if you've got someone though who does have clear left ventricular impairment on echo, I would label them as having that, even if they're asymptomatic and their MPP is relatively normal, and treat them with the 4 pillars. As always, if there are specific questions, because this is a kind of a learning process for all of us in terms of the QOFs, please come to us on advice and guidance.
Yeah, so we're working on, given this new QOF thing, in Durham and Darlington, we're working on a bit of a pathway to cover some common scenarios that like the ones you've just brought up. But it's going to be a bit of a work in progress, and we've said that if there's these grey areas, we'd be happy to deal with them via advice and guidance. But I don't know how many of them are going to come our way yet.
Thank you. Anyone else? Any other queries?
No.
No. Did you want to, Joe? Do you want to do the feedback?
Yes, please.
Quickly.
Yes.
And then we can draw things to a close, I think.
Yeah. So if people are able to just bring up your phones and scan the QR code, there's a few questions which we would like to quickly reflect on, and I think some answers come online, and it's just for us to see how we can frame the next discussions, but also just to gauge if there's any learning throughout the sessions that have been delivered. So yeah, I will wait for Christine. Is that the case? After they've people have scanned, would it show on the screen, or give you a few seconds just to scan? Then I think we need to move on to the next screen, which will start showing the questions. Is that moving, Christine? Whilst we try to sort this out, I think there's a question from Alison there.
Sorry, Joe. I need to show you a different screen to be able to show you the results.
Okay. All right.
Has everybody had time to do it? And if they have, then I can stop sharing and I'll show you a different screen.
Okay. So I assume people are answering the questions now, Christine, isn't it?
Yeah.
Okay, cool.
Alison, sorry, did you have a question?
Yeah, Alison had a hand up. Just waiting for the technology to work if it kicks in.
Yeah, there's still people voting there, Joe.
Oh, cool. Okay. Give it another minute or so.
Well, just while we're waiting, thank you, Joe, and everyone for organising this. And thank you ever so much to Aisha and Yaz for their wonderful presentations, and both excellent and very informative. And thank you everyone for your attendance today.
Yes, thank you. Thank you for sharing, Tom. And also, I think the next session will be on the 23rd of September, but the Eventbrite link will go out, but it will be totally a different topic around case finding in primary care. So we'll look out for that, but we'll be sharing the Eventbrite link very soon for that session. I suspect people are still voting.
Yes, there's still some people typing.
Okay. So the first question there was, before the session, please rate your knowledge out of 10. So I've got the results there. We'll be able to share the most of these results if people need that. And what was the next one? Okay. Yeah, that was more specific to the leg edema breathlessness session, that. And the next one was around Yas's talk around valvular disease, in terms of people's knowledge there. And again, that is post knowledge base after the session there. And the last two will relate to future sessions. Yeah. Okay. Yeah. This is about 61% of people changing their practice as a result of what they've learned, which is really good. And which setting, which is really helpful. So 39% were from primary and secondary, and we've got a few from community there. And 6% were non-clinical, which is really, really useful to know. Okay, other topics to be presented. So we'll Christine and I will go through this, and we can synthesize and share with our chair so that we can plan on to the next session. So all those sessions which have been listed. We've got 4 more sessions or webinars to deliver. So this is very helpful feedback. So thank you ever so much. Yeah, there's more. So there's more answers there. Right. I'll pass you back to Tom. Thank you ever so much for completing this, guys. I will synthesize this, but thank you so much, Tom, for sharing. I'll leave you with the last word.
Yeah, no, thank you again, everybody. It was really great to have so many people sign in for this, and hopefully we'll see you all for the next one.
Very much.